consequences of disease progression. We're letting people roll into the chat, so others are still coming in, and this presentation will be available. We'll have the links in there, and then a reminder of also there's going to be an evaluation on the last page. My name is Tammy Chambers. I'm a clinical quality consultant with Health Partners, and I'll be introducing our speaker today, Janet Ungs, shortly. This webinar is brought to you by these 6 managed care organizations called the Collaborative, which impacts the SNBC and MSHO populations. This performance improvement project, PIP, focuses on diabetes. All plans across the US serving Medicaid members are required to do a PIP. DHS collaborated with us to establish this as a priority project. All plans already have multiple initiatives in place to address the crisis. The PIP allows us to formalize this work and collaborate on interventions to bring them statewide. The project must be designed to improve quality of care and health outcomes, address a serious health condition, and improve member satisfaction, all with a goal to achieve significant improvement sustained over time. This PIP addresses all of these areas. Introducing Janet Ungs, nurse practitioner with a focus in endocrinology. She graduated from the University of Iowa, BSN, and of Missouri with an MSN as a clinical nurse specialist with an emphasis in diabetes. 20 years after that degree, she completed her family nurse practitioner program with an emphasis in diabetes and care management. She's held certification in diabetes education for over 20 years and has worked with diabetic patients for about 25 years total, the last 12 years of which as a nurse practitioner. She is practicing at Park Nicholas since October 2016 and was in Cedar Rapids, Iowa prior to that. Thank you, Janet. And she's having issues with her camera, so I will be advancing the slides and you may see me. The objectives of today's webinar are to discuss the incidence and cost of diabetes, discuss microvascular complications that impact the eyes, feet, and kidneys. Also review the 2022 American Diabetes Treatment Guideline recommendations. And then lastly, how to engage the patient as a partner. We can see by this slide that as we continue to work in improving diabetic care in our SNBC and MSHO populations, it's important to remember that optimal health outcomes are influenced much more by the socioeconomic factors affecting people and their families. Physical environment also contributes to the challenge. It's not just about the right medications and right tests. This slide is 8 years old. These factors have long been recognized and studied for many years, but the pandemic has brought it to the forefront of how much work needs to be done to address these factors. The social determinants of health is part of a cycle that is hard to break. It not only impacts individuals, but generations, and families continue to struggle. In this study in Japan, the research identifies how lower socioeconomic status impacts outcomes in diabetes. It looked at the prevalence of diabetic retinopathy between populations with low versus high incomes, either employed or on public assistance. In both cases, if you were poor, you had more complications from your diabetes. This is a study published in the Journal of American Heart Association in 2018, which not only highlights the gaps in outcomes, not just based on income, but also race. Amputation rates were reviewed for individuals with peripheral artery disease, which is a major complication of suboptimal diabetes management. For the white population, low income showed a higher amputation rate than those with high income. This blue arrow here identifies the difference between the purple and the green lines. More dramatically, however, the rate of amputation for the Black population showed a much higher rate of amputation for both low and high incomes, identified here by the red arrow. So in addition to the challenges of a lower socioeconomic status, there continues to be a wide gap in outcomes based on race for the care we are delivering. We have lots to do in this arena, so we are happy that Janet is here to help us learn some of the best practices to help our patients manage their diabetes and therefore have less complications and live healthier lives. Welcome, Janet, and I'm going to turn the slides over to you.
Thanks, Tammy. I just want, one thing we didn't talk about before is how am I going to tell you to advance the slides? So when I've been practicing at home, I just tell myself next.
Okay,
so
perfect.
That's the key word. Well, welcome everybody. So glad you all could make it today. Yeah, they said about 540 people. That's, what is that, about 1,080 eyes on me if I had a picture. But anyway, a lot of ears anyway. So among the other things we're going to talk about, we're going to discuss the incidence of the diabetes and cost, like it says here, and also a little bit about how these microvascular complications really how they occur and what kinds of things you can do to help your patients get the help they need, I guess, or what kind of help they do need to get. And the treatment guidelines we'll talk about in specific to not only diabetes, but a little bit about specifically to eye, kidney, and foot issues. And lastly, hopefully can give you some ideas of how to help your patient be more engaged. We use the word partner, and so that's kind of what we're going to be looking at. So as far as incidence and cost, the American Diabetes Association had some statistics that they published in about 2019. So remember, these are, because they were published in 19, they're really from probably 2018. And I'm looking forward to seeing them updated. But I have to tell you, in the many years I've been involved with diabetes, and Tammy, I should ask you, can you hear me okay?
Yes, we can hear you.
Perfect. In all the years I've worked with people with diabetes, it seems like it's always about 1 in 10 people have diabetes. I don't know why that doesn't change so much in America. It may have to do with the death rate and then the new diagnoses, I'm not sure. But roughly 38 million, 37 million Americans have diabetes. And you can see that almost 2 million of those people have type 1. So the vast majority of people with diabetes have type 2 diabetes, not type 1. Costs have increased, as you can see, from 2012 to 2017 by 26%. And you can pretty much be assured that it has increased at least that much, if not more, since 2017. But again, these are the most recent data I have. $327 billion a year just for diabetes. That's quite a bit. And that includes hospital costs, emergency room costs. Remember, when patients, no matter who they are, go into the hospital, it's in our country, we do not deny care. So those costs are going to not only insurers, but taxpayers and the medical system itself. So roughly 1 in 4 healthcare dollars are based or used for diabetes. And as you can see, the person who's over 65, that age group, tends to have the highest costs. Remember, those are the people that have the most incidence of type 2 diabetes and probably have other comorbidities or health issues that they come to the plate when they develop type 2. Okay, so go on to the next one. Oh, and something else about costs. An interesting fact is that the individual with diabetes usually spends close to $17,000 a year in medical care costs. And of that, about $10,000 is specifically for their diabetes. All right, so this is kind of a summary page of microvascular complications and where does it affect people with diabetes. Obviously, we have larger vessels, we have smaller vessels, larger vessels, and all of these vessels get affected by diabetes, as well as blood pressure and cholesterol problems. So especially with diabetes, we're not looking at a really simple disease process. It can affect all these areas pretty much head to toe. So it is a very pervasive disease. It's very difficult to manage. And as Tammy mentioned earlier, when you add in the socioeconomic issues that you're facing with your patients and emotional and psychological issues, it becomes almost insurmountable. All right, next slide. So microvascular complications, just to review, the eye, that's called retinopathy. Patients with diabetes are higher have a higher incidence for cataracts, glaucoma, and visual impairment. For the kidney, it's called nephropathy. And we'll talk more about albuminuria as we go along, and renal insufficiency. The nerves, the medical term is neuropathy, and it can obviously affect peripheral as well as autonomic, but we're going to be talking about peripheral in terms of how it affects the feet. Next. So how does microvascular complications happen? How does this actually occur in the body? Well, as I mentioned earlier, it's really three numbers that we used to call it know your numbers. And it's what is your blood sugar, what is your blood pressure, what's your LDL level, okay? So blood sugar's elevated, blood pressure elevated, and a higher cholesterol, particularly the LDL level, and that for people with diabetes would be over 70. All those things working together stiffen up these blood vessels. And when you're talking about teeny tiny microvascular blood vessels, the walls become stiff and they're more likely to break and bleed. And so that's where a lot of these problems come in, as well as the high blood sugar can irritate the nerves by taking away some of the protective coating on the nerves. Remembering that the smallest vessels that we have in our body are in the eye and kidney, so they are the most vulnerable. Next. So retinopathy or eye disease really depends on how long the person's had diabetes and how poorly controlled they had their diabetes. So remember that also as we talk about this, and I always feel like I'm giving the doom and gloom talk because it's the one talk that I did not want to do the most with patients because it is reality, but it's also can be very scary. The upside of it is if we can get patients to do a little more for their diabetes and take care of themselves, they're likely to have as healthy a life as anyone. And so it is possible, although there's lots of hurdles in the way. So when you have eye disease, likely to have kidney disease, again, because the blood vessels are of similar size. Okay, next. So with retinopathy, now they have the word DR, the initials DR, so you'll see that, they're here. And you also may hear the word diabetic retinopathy or diabetic nephropathy. I personally shy away from using that term diabetic. And because it's kind of puts a stigma on the person, a label, if you would. So when you say diabetes, it's a person with diabetes, and that's who we're working with. All of you know that. All of you are trying to reach that person. So if you can, that would be my one request from today is try not to use the word diabetic because it's a person with diabetes. But so these people with diabetes, after 20 years of having it, there's a very large amount of problems with eye disease. All patients with type 1 have some evidence of retinopathy. That's really significant. All patients, not just some of them. 60 to 85% of the people with type 2 will have some evidence of retinopathy. It is the leading cause of blindness in people 20 to 74. And again, laser treatment can help reduce the severity by 50 to 60%. Control the diet. Correct, Stormy. If a person can, the main thing is keeping their blood sugars in control in whatever way they do that. So if it's just by diet control, great. I will tell you that current guidelines do not even start a person on just diet control anymore. So even with someone with type 2, for example, the standard is to start them on metformin and seeing a dietitian education. Okay, next. So these are some, every medical talk has to have some creepy pictures, and here are mine. So these are actually pictures that came from the International Diabetes Center, and a lot of my slides are from them as well. So a big shout out to them. But as you can see on the far left, the microvascular damage. The little blood vessels are the dark red squiggly lines you see. And then if you see those little red blobs, that's where the blood has actually leaked out into the tissues from the blood vessels, okay? Then as you go to the right, swelling of the retina, you can see even more pronounced some of those things, but particularly in the red picture on the right, big blood blobs, as well as a lot more teeny tiny vessels. And that's called neovascularization, a fancy word that says new vessel formation. And this is true in any part of your body. If you lose flow of blood to your leg, for example, other blood vessels will start to grow to try to bring blood flow to that area. With the heart, same thing. And you can see, though, these tiny little blood vessels that are trying to revascularize the back of the eye are way smaller than the original blood vessels that were there. So they do an okay job, but it's not going to be exactly the same. Next. So what does diabetes, retinopathy and diabetes look like? You can see on the little picture on the left there, those two little boys with their balls, normal vision, right? But on the right, you can see that blood that I was talking about, those blobs of blood actually block areas of the vision from the optic nerve that comes from the back of the eye. So that's what you see, is you can't see parts of your field of vision, and it can be blurry. So it's pretty dramatic. Next. So the ADA recommendations for people with diabetes, whether type 1 or type 2, they recommend that you get an eye exam at the time of diagnosis. If eyes are stable in the person with type 1, they recommend about every 5 years. And of course, that's up to the eye doctor. Type 2, though, at time of diagnosis and every year after that. I have a lot of patients that are seen more often than that because they have active eye disease. So disturbingly, of course, 40 to 50% do not receive the recommended eye care. And according to a Joslin study, 93% of patients with retinopathy and 63% of vision-threatening retinopathy don't even have any idea they have retinopathy. And if you can imagine, there's no pain involved with these changes. It's not like you can, I can feel that bleeding into the back of my eye. You can't feel that. And so if you have a large amount of patients that aren't even going for a general exam, they can have a very sudden onset to them. They might think this is a very sudden onset of visual changes, when actually it's been building for years. And as you can see, even with vision-threatening retinopathy, the vast majority of patients don't schedule their follow-up eye exams. Okay, next. So what we do know about retinopathy is that regular eye exams, hopefully I've made that pretty evident, are absolutely important. Blood sugar control, blood pressure control, again, we've said that, but trying to get your patient to quit smoking, and that's always a big bugaboo to get people to do that. But even if you can get them to start slowing down how much they smoke, that's at least going to make some improvement. And women who are planning or are pregnant should really get their eyes examined, because even though they might get their blood sugars in control, in the best of all situations, they're not going to be able to do it as if they didn't have diabetes, if that makes sense. So what happens is women who have some eye disease at the beginning of pregnancy probably is going to have a little more eye disease by the time the pregnancy is over. So at the very bottom, there are several medications we try to use to slow the progression of retinopathy. The top is a medication to lower blood pressure. Fenofibrate helps with sometimes with cholesterol, but also just with eye problems. And then, of course, laser treatment is the gold standard for treating macular edema. Next. So we're going to go on to kidney. I don't see any other questions. So kidney. All right. So again, same sort of slides, same things, blood pressure, glucose, and LDL, knowing their numbers. And these things affect the filtration unit of the kidney, and we'll talk a little bit more about that. Next. Okay, so here's your big $10 word you can spread around the office and sound real, official. Glomerular filtration rate, okay, GFR. And this is something that we measure once a year through blood work, and it really helps drive our decision making about, what kind of medicines to use, when to start medications, all that has a lot to do with it. So, so in your kidney, if you can imagine, your kidneys is roughly the size of your fist. And in that kidney is about 1 million filtering units called nephrons, okay? So that little nephron is, if you can think of it like a sieve, okay? When you have a sieve and you're, rinsing your vegetables or whatever, you're running water over it, the dirt's going in the sink and you're keeping your vegetables. Well, with the kidneys are actually filtering the blood. And the blood has certain components in it that the body knows, okay, that needs to go in the urine. And then certain components need to stay in the body. One of those components is protein, and it's the smallest molecule, okay? So when this sieve is affected by blood pressure, blood sugar, and cholesterol levels, those little holes, for lack of a better word, get a little bigger. And when they get a little bigger, the first thing that they see in the urine is protein. Now, this isn't something that the patient can, quick turn around and look in the toilet and go, oh yeah, there, I see that protein. It's not something that can be seen. It's not something they feel. It's only detected with a yearly urine test, okay? So it's a rough measure of, the GFR is a rough measure of the number of filtering nephrons. And it's not measured directly, but it is something we do with blood work, like I said. Okay, so next slide. So as you can see, and again, this is an older slide, but the greatest majority for kidney failure in the US is from diabetes as its main cause. Next slide. So stages of chronic kidney disease, this is what the nephrologists or the kidney specialists use to decide at what point do we start dialysis, okay? So stage 3 is, we start doing interventions, and then 4, again, they're just being followed. And then by the time they get into stage 5 and their GFR is actually under 15, that's when discussions of hemo or peritoneal dialysis start happening. So as you can see, if you look at stage 1 and stage 2, we're all either stage 1 or stage 2 kidney failure, which I think is kind of an unfortunate designation, because I don't feel like everybody has kidney failure or kidney disease, but apparently that's how the nephrologists look at it. Okay, next. So recommendations for screening. For nephropathy, we want to look at the urine. Like I said, we're checking for albumin, the protein in the urine, as well as the GFR, which is measured by a blood test. For people with type 1, generally those are younger people, so they don't come in with a lot of, to the disease with a lot of chronic issues to begin with. So usually after they've had diabetes for 5 years, they start checking for kidney issues. And then with type 2, of course, or if they have hypertension, we start that right away. But type 2, again, because they're an older patient, we start checking that right away. Next. So these are, terms you don't have to necessarily remember, other than knowing if you want to know the ranges. But what I'm looking for when I do a test is the normal. So under 30, it's fine. 30 to 300, I'm repeating that test. You can go ahead and click the next one. But you can see that when it gets to that range, it's increasing your cardiovascular risk just in that very first stage. Now, once it goes over 300, that's increasing the risk for end-stage renal failure, which is the dialysis time, it increases the risk, okay? And then you can, yeah. So a lot of times we do 2 or more samples. but I will tell you that in practice, if I see a patient that their reading is over 300, I immediately send them to nephrology and put in a referral for that because they need a little more monitoring than just what we're able to do. And a lot of times it's a blood pressure issue too. And so we'll talk a little bit more about that in a minute.
And
Next.
then Janet, yeah, there's
Yep.
a question from Katrina. Is any of this reversible?
Yeah, I was going to try to address that in a second, but
Okay.
it depends on how bad the disease process is. Now, when you're in the normal range, probably, you know, and when you say reverse, remember that it's a constant battle with diabetes. It's not that if his or her albumin level goes down under 30, that it's never going to pop up again. It all depends on that fluid control of blood sugar, blood pressure, and cholesterol. And it depends. I mean, if someone's in, you know, stage 4 or 5, you know, depending on what their blood pressure control is like, it's, you know, they might not. So that's the sad part about this, is like eye disease. It's not like, you know, in that picture where all the little neovascularization was happening, it's not like those little small extra vessels disappear. Those are there. And so, yes, some of it can be improved, but it's probably not going to completely resolve, no. And so that's, to me, that's the scare factor. That's the thing that makes it hard for people with diabetes to deal with the disease, is when they know those things. So, yeah, next. So treatment of nephropathy, trying to keep the A1C under 7, and smoking cessation, you've seen these before, and keeping lipids down, aspirin for blood flow. Not all patients are considered good candidates for aspirin, so I generally check with the endocrinologist or the primary care for that determination. A low protein diet, if you can have the patient see a dietitian to get some good ideas on what they need to do for that. And then the blood pressure medications. You know, generally we start with an ACE, but if a patient needs more than one medication for blood pressure, and I would like to say that most patients do, many patients need up to 3 different classes of drugs to control their blood pressure. And when they get to that point, when one agent isn't doing the deal, then that's where I send them on to a primary care or someone who's able to manage that better. Down in a patient's home environment, like homes. I don't think so. I don't think that somebody asked if there's a kit that someone can take home to do. I don't know of any. And a lot of that has to do with the way labs control the integrity of the test. So as far as I know, there is not a test like that. Next. So blood pressure control, you know, overall the goal is 140/90, but most of my patients I really work at trying to get it close to that 130/80 or less. And it talks a little bit about starting blood pressure medication, which I don't think we need to go too much into that. But like I said, most people need more than one blood pressure medicine. Okay, next one. All right, so feet, we're gonna move on to the feet now. And you know, how does it happen? The same thing, you know, it's all those 3 things. Now the thing with the nerves that I wanted to make a comment on is that when the blood sugars are high, they actually wear away this protective coating that the nerves have. It's called a myelin sheath. And basically it's a little fatty protective coating. And if you think of it like a telephone wire, when we used to have telephone wires outside, not buried like they are now, that protective coating helps send the signal from house to house. Now we have cell phones, so we don't have to work about protective coatings on our telephone wires. But same thing, the signal from the foot to the brain and those nerves, if that protective coating is worn away, the nerve can't send the signal as quickly. So you see people lose their ability to protect their foot. What do I mean by that? Well, if I step on something, I know it right away. You know it. Most of you know it. You feel something sharp or whatever. But if you have nerve damage to your feet, you could step on a tack and not know it. That sounds pretty dramatic, but I actually have had patients step on things, not know it. Piece of glass. Had one patient many, many years ago who walked around with a golf ball in the boot. Did not know it either. So it can be pretty dangerous if they lose that protection. They can't feel pain. The other thing is that, we want our patients to look at their feet every day, but as they get older, they get less flexible. It's harder to reach down to their feet. It's harder to see them because their eyesight has changed. So those things can be a problem. Next. So signs and symptoms, lots of different things that your patients might talk about that cause problems. Numbness, tingling, burning, pain are probably the most common. They tend to be worse at night because that's when, you turn off the lights and you're settling down in your bed and there's nothing really to distract you anymore. So those things, it's not unusual that people say it's much worse at night. I don't notice it during the day. And then diminished vibratory sensation, which we'll talk about that. But they can also say, well, it feels like I'm wearing socks or mittens on my hands and my feet. So that's also can be a sign. Next. So the foot exam, once a year at least, we like to look at people's feet in the office. And if the primary care does it, that's great. I just want someone putting their eyes on patients' feet once a year. And that's actually a standard by the insurance companies. So, so what we're looking at is the skin between the toes. Of course, I don't really pull my patient's toes quite like that, but you can still see between them without doing quite that much. Anyway, so you look between the toes, you look at the nails, you're looking for any problems, little cuts or scrapes or things that don't seem to be healing. Very common for people to have dry skin. So those are opportunities that I take to talk about foot care as well as looking at their feet every day. Those are things they can do. Taking pulses is another part of that exam. The middle picture shows the monofilament or a monofilament that we use, and don't really do it so much on the top of the foot so much as I do on the bottom of the foot and the pads of the toes. And so I just check and see, make sure it's a very light touch, and I want to see if they're able to feel that. And then the tuning fork in the bottom picture, that's to test that vibratory sensation that we were talking about. And you hit the tuning fork and place it on that knuckle and see how long they can feel it. Of course, the important part of all this is that you have the patient close their eyes so they can't actually see when you're touching their foot with the monofilament, with the tuning fork, and then you can really tell that they're able to give you a better assessment of that. Next. So the American Diabetes Association updates their guidelines every year, and in 2022 is no different. First thing which I thought was interesting, and this is a change, is that screening now for diabetes is recommended to start at age 35, and they're looking at A1Cs and blood glucose levels. So fasting blood sugar, if it's over 125, that's considered diabetes. And a random blood sugar, in other words, anytime during the day, if it's over 200, that's considered diabetes. And my last check on insurance guidelines, you have to have those actual blood sugars as part of the diagnosis to be diabetes. Now, A1C, if it's over 6.5, and that's a 3-month average of what the person's blood sugar has been. If it's over 6.5, that's considered diagnostic for diabetes, according to the ADA, but not necessarily insurance. So I wanted to make a quick comment, though, about elderly patients and goals for A1C, and we'll talk a little bit more about this as we go along also. But when patients get older, and what is older, Janet? It could be 60s, it could be 70s. People's age in their body depends a lot on a lot of different factors. But as people age, their kidneys don't do as well, their hearts don't do as well, their blood vessels just naturally become more stiff. So the problem with having a 6.5 goal for A1C, and we'll talk about why that is, why we have 6.5 as a goal. If it's 6.5 as a goal in an elderly patient, to have that without low blood sugars is pretty hard to do. Because their kidneys aren't working as well, they don't process the medication quite as well. So they might process it very well one day and then process it very quickly the next. So if you have an elderly patient or a person with kidney or heart disease have a low blood sugar, it actually could be something that could be fatal. So we don't want to drive it too low. Daily blood sugar levels are critical in really evaluating the kind of control. I never look at just the A1C if possible, and because it's an average. So if you think of what average means, I mean, an average could be anywhere from, over the previous 3 months from 40 to 400. Well, that's not good control. We want to have the range of blood sugars tighter than that. So it's not just that the A1C is good. We need also to know what the daily control is like. So that last little statement there, that's when we get sensors going on patients. We try to get their blood sugars between 70 and 180, 70% of the time or greater. And that's over a 24-hour period. The only way that can be measured is through sensor technology. Next. So, okay, so we were talking about, why do we decide on these different A1Cs? Okay, so this is from a research study called DCCT, Diabetes Complications and Control Trial. And it is probably the strongest piece of research evidence we have, because it's been over, a research project that went over 20 years, and it has thousands of participants, okay? So what they did is they watched these people over that amount of time and then would marry up how their A1C did with what kind of complications they had, okay? So if you look on your bottom axis there, you got 6, 7, 8, 9, 10, 11, 12, that's the A1C. And then on the left axis, you have relative risk of complication. So the blue line, as the A1C went up, the relative risk of complications increased. And you can see about 6.5 is right when that starts moving upward. Even at 7, you can see a big change just from going up to almost 2 times the risk. And then look how it goes here, 9 and then 10. It really escalates very quickly to causing problems from high blood sugars and complications with diabetes. So if you hit the next button, yeah. So lowering the blood sugar significantly reduces vascular problems in both type 1 and type 2. Remembering the statement I told you about the elderly patients, we don't keep them at that 6.5 level. If they're and especially if they're having lows, it's not safe. Okay, next. So you can see it's been verified by several other studies that intensive diabetes therapy, what does that mean? It means multiple injections of insulin, not just, we take one, shot of NPH a day and that's it. But by intensive diabetes therapy, really watching all the things that affect blood sugars, complications can dramatically reduce. Next. So priorities of care with adults with diabetes. Look at this huge slide. There's so many things that these patients have to be thinking about and doing, and in order to have best control. So what we've been focusing on today is the microvascular complications. And if you click one more time. Yeah, so that really is key in annual screening, okay? So kidneys, eyes, feet, all of those are just annual exams. Okay, so next. So engaging your patient to partner with you. Now, so diabetes, like I said before, is a little different than just having maybe blood pressure problems. Blood pressure problems, you can take a couple pills and, maybe you can modify your diet or maybe you can't, but, it's may or may not have a dramatic effect on the blood pressure. But if you have diabetes, you are really looking at a lot of different factors. I think we've seen that pretty clearly. And because of that, your patient will do better in their diabetes if they feel like they're working with you, with their provider together and making decisions together. That's really my goal with my patients. I don't want them, I have a few that will say, well, it's whatever you say. Well, I don't want to do that. I want them to understand what we're doing and to come to a decision with me because they live with their diabetes 24/7. I only see them for maybe 20 minutes every 3 to 6 months, right? So they really need to be a part of this whole process. So our goal is really to keep patients out of the hospital or the emergency room. And when I meet with patients, I'm trying to really establish rapport with them and have them feel like they can trust me. My biggest motivation for patients is to have them come back. Research shows us that patients who come more regularly do better with their diabetes. Patients who go through education processes do better with their diabetes. So the only way they're going to do that really is if they see you and they know you and they trust you. Okay. So I try to listen with a non-judgmental attitude. We've all heard this before. And I really want to emphasize no scolding. Believe me, your patients who have had diabetes for a while, or even the new ones, they get scolded. And if, I don't know about you, but if I get scolded, I don't really want to have an interaction again with that person. So they also know about complications. They have neighbors that have it, they have friends, they have families that have diabetes, and they get told that all the time. So scare tactics never work. It doesn't motivate the adult learner, okay? So moderating your expectations. The patient is not going to be perfect. I have very few perfect patients. In fact, they're very far and few between. My goal really is to just move them forward. And hopefully in my examples, I can help you understand what I'm talking about. I do like to thank them for their efforts, not only in coming, because a lot of times that's the biggest hurdle. Like I said, they've been scolded before. They've never seen me. They have no idea. What am I going to say when they come in? So I thank them for coming in. I thank them for testing their blood sugars. I thank them, hey, good job on taking your shots and, recognizing their efforts. It's really important. Okay, next. So I got a few cases. My first one is a fellow that I've worked with for a few years, type 1. He's a young man and has several emotional, psychological hurdles. Attention deficit, oppositional, he's defiant, he has autism. He's really a very smart man, but he has diabetes type 1, and he's a very heavy smoker. So my very first visit with him, he was very angry. I had read in the chart that he didn't like the doctor he had seen before. And this particular doctor is very nice. And I thought, well, he's going to have my work cut out for me today. But he went on to tell me how he didn't like this doctor and he didn't like that doctor and he wasn't going to go back. So he was really throwing up a lot of fences. I don't want to do this. I don't want to do that. I want to do that. He did have pretty poor control. His blood sugars were always 300 and 400 or more. And to complicate it, he wasn't a good historian, meaning that every time I asked him, well, how much insulin do you take? I'd get a different answer. So next slide. So with this particular patient and with, particularly patients that I know are going to be coming in angry, is I just wanted to listen. I wanted him to tell me his story, so to speak. Just get him to come back was really my biggest thing, trying to help him feel comfortable with working with me. because that's better to have a touch with somebody who does this, a visit, than to avoid altogether. I did communicate with his caseworker to help fill in some of the gaps and help with reinforcement of what I was talking about during our appointments. So the Void Hospital, he, at one point after I had seen him a few times, had some very serious heart problems, chest pain and shortness of breath, and went into the emergency room, at least he did that, and they wanted to admit him for further testing because, like I said, he's pretty young. He's had diabetes a long time. He could have a heart attack. He could have a stroke. And they wanted to admit him, but he said, no, I'm not going in because I can't smoke when I'm in the hospital. So if I had just only seen him one time, I couldn't have said to him what I did say. And that was, when you go to the hospital for something with your heart, it doesn't make sense for these people who are trying to help you to let you continue to do the thing that's making you have this heart disease. So he really actually thought about that. And he actually eventually did connect with the cardiologist practice. And I think I have one more slide on him, maybe. Yes. So, and actually I got a letter about a week ago on him, and he's actually doing a little bit better. He's actually following, instructions. He still has ongoing problems. His ADD doesn't go away. He's not going to become not autistic. He's not going to be out of a, assisted living facility kind of thing. He's not going to do that. But it's really looking at those small changes, those small steps. He's more calm. He listens to me. He's taking his medication for his emotional issues more regularly. All those things are good. But am I ever going to get him to where his A1C is under 7? I doubt it. But it'd be better than staying at 12. Okay. So next.
Oh, and there's a question. I don't know if you want to look at that real quick.
A question. Let's see. So they're bad at checking blood sugars. Do you have times a day that you do that? Okay. So, so if someone isn't checking, this is really a good question. If someone isn't checking at all, okay, not doing any checks, towards the end of the visit, after I've had a chance to talk with them and, for lack of a better word, sort of schmooze them and make them feel more comfortable with me, is I say, what do you think about testing your blood sugars once a week? Take whatever they started at, once a week. Now, you and I, we all know that's pretty much useless. But in terms of starting a new habit, that's the first step, right? So maybe you check once a week. And if you can, what about, and if they say, okay, that's all I could do. Okay, well, how about if they don't really kick and fuss about that? Well, maybe would you check, first thing in the morning a couple times a week or 3 times a week? And what will happen is eventually they'll start seeing these numbers and realizing, hey, I need more help. Or I can do something about this. And so it kind of builds these habits that you're trying to get them to do. So ideally, if you're on insulin 4 times a day, you should be testing fasting, before lunch, before supper, bedtime, and anytime you feel like you're having a low. So that's at least 4 times a day, right? If they're on pills, I like to do it first thing in the morning and then alter maybe the second test of the day. So they do fasting and then before lunch, and then fasting and before supper, and then fasting and bedtime. And if they still kick up a fuss, I say, well, could you just do that like a week or 2 before you see me or before you see the doctor? Either way, you're still getting some good information and starting to build a habit. And somebody else has another question here. How have an insulin? Oh, so I would have to tell you that sensors and pumps are really, really good tools. And again, they're tools. They don't solve everything. This little guy that I'm talking about right now, I actually got him on a daily pump. And this way I know he's getting insulin, all the time. It's not perfect, but it's better than him missing insulin. Okay, so sensors are great. They really have revolutionized our ability to care for patients with diabetes. But again, all these things cost a lot of money. So it depends on what their insurance as to what will work for them.
And it looks like Rebecca raised her hand, and I don't know how to, if she can
Yeah,
just,
she's gonna have to write something in the chat.
okay,
I
Yep.
can't call on her individually.
okay, okay.
Yep.
We'll get to, yeah, I'll have her write it in there, and then I'll go to the next one. And we have about 8 minutes left, Janet,
Okay.
just for a question, just to let you know.
Yep. So case 2 is a male that I saw about 3 years ago for the first time. Let's say you're getting insulin, need to check 3 times a day or more, the sensors are not covered. Correct. For some insurances don't seem to care if they check or not. So it just depends on the insurance company. It's all very different. So back to case 2, I saw him about 3 years ago where he said he had some little spots on his foot. So I took a look at his little spots, and he had, you know, what I would consider pretty significant sores and that on his feet. And at that time, I recommended him, you know, what he needed to do. And then he was gone. And a year later, he comes back and he says, yeah, I said, how are those sores doing? He said, I still have them. And when I looked at them, they'd gotten a lot worse. They'd gotten a lot more expansive. They weren't bleeding, they weren't infected, but it could very well be that it had gotten into his bones, and that's not something like you can see happen. But they were non-painful. His biggest hurdle was the fact that he was afraid to lose his job. So he was not willing to do what I really wanted to do, and that was to go to urgent care or emergency care, which emergency is probably the better option in his particular case. He wouldn't do it. So he did agree, though. So we were able to make progress because he did agree to something, sort of like a negotiation back and forth. He did agree to see podiatry, and he saw them in about a week. He did get some good wound care, and he is making progress. But not surprisingly to me, he hasn't been back to see me. He's getting the care he needs. He's had appointments, but he's been a no-show for those, which is unfortunate. Okay, so next slide. And then this case 3 talks about food insecurity. I have a gal who was pregnant at the time, several mental health challenges, but what she would do is drink a lot of Diet Mountain Dew a day. What she would admit was 4 cans a day, remembering that 1 can has enough carbohydrate for a whole meal. And you might think, well, you know, at least they get something. But the problem with anything really heavily sugared like that is it really raises the blood sugar. And during pregnancy, we try to keep their blood sugars so tight, it's almost as if they don't have diabetes. So I knew she wouldn't go for not drinking it at all. I tried that, and she was like, no, I can't do that. So I go for what I call the low hanging fruit and just trying to decrease the amount of pop. So we eventually got down to 1 can a day. And of course, I'm relying on the reports from the patient. In other words, she's telling me what she's doing. I have no idea if she actually did that. I'm hoping she was able to, but that's kind of what I'm talking about, is making some change. If we all had our druthers, yes, stop drinking the Mountain Dew and either drink diet or water. But by decreasing the amount of pop, I was at least getting her to set up a more healthy habit. Next slide. So remembering that you want to encourage patients to come and see a provider on a regular basis, the American Diabetes Association actually recommends that people with diabetes be seen every 3 months. I would say the majority of my patients I see every 6, and the patients that I see every 12 tend to be needing a lot of interventions, things that I can't really address real fully in the short amount of time I have with them. And so having them come every 3 to 6 months is going to be far better for them. And remember that research that I was mentioning, the more often they come, the better they're going to do with their diabetes. I would encourage them to have an annual exam for their feet and eyes, as well as labs. And again, your primary provider can do a lot of this. Obviously, the eye exam has to come from an ophthalmologist, not primary care. Again, the goal is to keep them out of the hospital, the emergency room, establishing trust, listening to them. And remember that any progress is good. You know, anything we do, we're trying to establish better habits, and then realize your limits. You know, I used to, you know, when I first started working with people with diabetes, by gosh, they just had to four times a day with the testing and all the, it's just a really hard line. And I realized pretty quickly that if I really wanted patients to come back, I needed to work with them and become a partner with them. So that's how I do it. And I think that's our last slide. If you go ahead. Yep. So any other questions? Go Hawkeyes. Yes. Hello. Thanks, Lori.
Yeah. So if there's any questions, and also a reminder, the evaluation link. And then Nicole, if you want to speak to that a little bit more, and then we'll monitor for questions too, to see if any more come up.
Yeah, so we put the evaluation link in the chat. So if you want to go ahead and click on that, we really do like to know what your feedback is. We do use that information going forward to make these presentations better and more informational for you. And then also, I believe when you click out of when the webinar itself closes down, the link will also pop up for you there. And then don't forget to check out the website page, because you can also find the recorded webinar there, and you can find the evaluation link there, and you can find out information about the upcoming webinars there as well.
And somebody said they couldn't get the link to work. I think Jenna resent it. And then
Jenna, will you resend it again one more time in the to the SharePoint website?
I think she did. And then also, does it lead them right to I think the presentation was up further in the chat. Is that correct?
Yeah, and then on the website page, the presentation is also linked there.
Yes, I also added the link to the website and the evaluation link. So
perfect.
Great.
So everything you need should be right there. So thank you all so much for participating.
Yes, and Janet, thank you for a great presentation, and really appreciative of everyone that attended. And if you have any questions, please reach out to Stratus, Nicole, or any questions that you have. But I really appreciate everyone attending today, and have a great rest of your day.
Thanks so much, everyone.